Hello, and welcome to today's episode of the Pediatric Consult. I'm Dr. Paul Bunch, a community pediatrician in the Cincinnati area, and your host for today. I'm in the studio today with Dr. Nicole Sheanon from the Division of Endocrinology at Cincinnati Children's Hospital Medical Center. Today's discussion is on type 1 diabetes, and specifically some new advances on early screening and early prevention of type 1 diabetes. So, first of all, Dr. Sheanon, thanks for joining us today. Can you tell us a little bit about yourself, about your training, what brought you to Cincinnati, some of your clinical interests?
Sure. Thanks for having me. As he said, my name's Nicole Sheanon. I'm actually originally from Cincinnati, born, raised, undergrad, and med school here. Left for Massachusetts and did my residency training at UMass in Worcester. Did a chief resident year, worked as a hospitalist for a year there, and then came back for fellowship training here at Cincinnati Children's, and then have stayed on in faculty. My primary area of interest is type 1 diabetes. I also see some patients with Turner syndrome and general endocrinology. I am also the medical director of our local diabetes camp for kids with type 1 diabetes. And I have a husband and 2 kids, and we like to go canoeing and go to Kings Island and do all the fun Cincinnati things.
Great. It's good to have a fellow Cincinnatian in the room. So today's discussion, as I said, on type 1 diabetes in pediatric patients. And most of us have seen kids with new onset type 1 diabetes, definitely during residency. I've had multiple in my office where you have a kid come in with those classic symptoms of polyuria, polydipsia, weight loss, things like that. So first of all, just to get kind of a baseline, is there a typical age of onset of these symptoms in kids, and how do these kids with type 1 diabetes most commonly present?
So there's actually a couple different spikes in time where we can see new onset diabetes. So there's a small spike in like the 2 to 5 year old range. There's a bigger spike around the time of puberty, and then also around sort of college age kids going off to college. But around puberty is the most typical spike, sort of between the ages of 8 and 12. We'll see a lot of new onsets. We have about 200 to 220 new onsets a year here in Cincinnati Children's in our catchment area. That's similar to other large institutions. Some with bigger catchment areas will have up to 300 to 400 a year new onset type 1 diabetes. Still in the United States, most common clinical presentation is in DKA at new onset. So symptoms of increased thirst and increased urination that eventually lead to weight loss, fatigue, vomiting. They'll come in with that Kussmaul breathing, acidotic smell on their breath, and require an insulin drip, sometimes the ICU if they're in severe DKA.
Okay. And this might lead into our next topic, which is our understanding of the pathophysiology, but why do we think that kind of pre-adolescence, puberty age range is our most common age of presentation?
So still, even after all this time of knowing what diabetes is, we know that there's a genetic predisposition, and then there seems to be a second hit or a trigger that then leads to the presentation of diabetes. And through research over the years, we have a better understanding that these antibodies that are known to cause diabetes, so they attack the cells that make insulin, your beta cells, can be present as early as 1 or 2 years of age. And that the more antibodies you have, the higher risk there is to progression. But even with just 2 antibodies, your lifetime risk of type 1 diabetes is 100%. We think adolescence and puberty is a time where your body often needs more insulin. And so that stress can often sort of lead to an impetus of the pancreas has been attacked. It's not making as much insulin at a time where you need more. It just can't keep up. And so then you have progression and presentation.
And these autoantibodies, do we think that are they coded in that patient's genetics, or do we know where they're coming from?
So there's genetic risk factors. So HLA factors have been used to sort of define people at higher risk. So there's been studies even looking at babies. And if they have positive HLA genetic risk factors, they've then been screened for those antibodies. And we can see those antibodies appear, as I said, as early as age 1. They kind of peak at age 2. But you can see them sort of develop at any time between ages sort of 1 and 18. What's kind of interesting is if you don't have antibodies by the age of 18, you're very low risk to develop antibodies after that and to develop type 1 diabetes in the future. And so with this knowledge that's sort of been coming over the years, there's now been a classification of stages of diabetes. So we think of type 1 diabetes new onset, that is stage 3, frank hyperglycemia, A1C greater than 6.5, random glucose over 200 with symptoms, that's the time that a lot of kids need insulin started. There's even some nuanced debate as we are starting to screen people more and catch diabetes earlier. Is there a stage 3A where like A1C is 6.8, you know they have type 1, they have positive antibodies, but they don't have the frank hyperglycemia quite yet, and so you don't quite need to start insulin right away. But that's one of the advantages of screening.
Okay, so then walking back from, stage 3 is that, frank hyperglycemia, symptoms presenting. What steps come before that, and how has our understanding of that evolved over time?
Yeah, so the ADA, along with other organizations, the American Diabetes Association, along with ISPAD, which is the International Pediatric Society for Adolescents with Diabetes, have developed stages of diabetes. So the first stage is really the at-risk group, and that's when you have 1 antibody present. Stage 1 is when you have 2 antibodies, completely normal blood sugars, and no symptoms. Stage 2 is when you have 2 antibodies or more, and you're starting to have some abnormal blood sugar. So we classically think of that as the pre-diabetes. So A1C of 5.7 to 6.4. Your post-meal blood sugar might be in the 140 to 199 range. Your fasting blood sugar might be in the low 100s, between like 100 and 125. And so those are your stage 2 kids.
Okay. And then beyond stage 3, is there a stage 4?
There is a stage 4, which some people argue, like, is that really necessary? It's just long-term diabetes. It's thought to be that's the stage at which you are no longer making any insulin. So often after new onset, once we initiate insulin, a lot of kids will have what we call the honeymoon period, where, to get to the point of needing insulin, about 90% of your insulin-producing cells are destroyed, so you only have about 10% or less left. Once you start insulin, those cells kind of get a break and a reprieve, and then they can start producing a little bit of insulin again. We see that over typically a period of 5 years, that completely goes away, and then that's sort of how they define stage 4.
And you said that our most common presentation, unfortunately, is still DKA.
Correct.
So, when those kids do present in DKA, does that have any long-term consequences on their outcomes, on their management, versus catching those kids when they're hyperglycemic but not in ketoacidosis?
Yeah, so unfortunately, DKA has a high risk of morbidity and mortality. And so unfortunately, every couple of years, we have a kid who presents in severe DKA, pH of 6.9, very sick, and can have neurologic consequences or even in severe cases, death from new onset diabetes and severe DKA. Most kids come out of DKA and do well, but we know from a couple of different studies, SEARCH being one of them, that if you're in DKA at diagnosis, you have a little bit less of a honeymoon period. You have risk of more severe hypoglycemia in the first 5 to 10 years after diagnosis. And you tend to have a higher A1C than those that did not present in DKA. And that sort of higher A1C is seen sort of sustained over time. And so it really seems to affect sort of that beta cell function and reserve, so they have less of a honeymoon. And there's a lot of sort of discussion now with the staging and trying to preserve beta cells with immune modulating therapy, that sort of preserving some insulin secretion is of benefit even in those requiring insulin, that there's less severe hypoglycemia, and, you know, a little bit easier to control diabetes and sort of potentially decrease risk of complications based on the diabetes clinical control trial that everybody probably learned about during med school.
Okay. So the short answer, the simple answer that I would understand is if we catch them before they go to DKA, they do much better.
Correct.
If they get into DKA, yeah, most kids come out of it. I mean, I remember in residency, those are the kids where you can take them where they look horrible. Several hours later, they're sitting up and wanting to eat.
Yep.
But if we can avoid that stage, their long-term outcomes are much better.
Correct.
So that gets us into screening.
Yes.
And that's probably more, you know, obviously your area of expertise, but a lot of that might sit in the pediatric primary care office. How is screening done?
So the way to screen for type 1 diabetes or risk of type 1 diabetes is to check for antibodies. And you're exactly right in that it kind of does sit more in the primary care physician's plate, because our patients are the patients that have diabetes, but their siblings are not our patients. Their siblings who need to be screened are your patients or the patients of primary care docs. And so as this area of sort of screening for type 1 expands, you and others in primary care, both adult and pediatric, may be starting to get more questions on how do I get my kids screened. And so the easiest way is to check the antibodies. So that can be done a couple of different ways. Here in Cincinnati, we have, it's called the iLet autoantibody screen, and it checks for 4 of the clinical antibodies we know that are associated with type 1. So the insulin autoantibody, IA2A, which is also called ICA, GAD, which is one of the more common ones, and then zinc T8. And so that one blood test will check for all 4. Our antibodies currently get sent out to the Barbara Davis Center. The assays to check for antibodies are hard to perfect, and so we send ours there because they have the most accurate and sensitive assay. It usually takes about 7 to 10 days to get those results back, and they come back as antibody titer levels. And so you'll get an antibody titer for each of those 4 antibodies. If 1 is positive, that's that at-risk stage. If 2 are positive, stage 1, and so on.
Do you see kids who get to like 3 or 4 positive antibodies, and how does that affect their progression or the speed of which the symptoms begin?
Great question. So, and just to step back a little bit, at new onset of diagnosis of diabetes, whether it's clinically type 1 or type 2, all of our patients in the Cincinnati area are checked for antibodies to kind of confirm the diagnosis, because we want to separate it from type 2 diabetes. We want to also clarify there's more rare forms of diabetes called monogenic diabetes. And so all of our kids are checked for antibodies, and we do find some type 2 patients that have positive antibodies. And also with the epidemic of obesity, we're seeing more patients with obesity who could present as kind of type 2 that actually have type 1. And so we check antibodies at new onset in everybody. I have a prevention clinic, so I've actually been following several patients. Even before this screening came about, we used to be part of TrialNet, which is a research study that screened first-degree relatives, and we were a site for that. And so we would see patients. I've actually had several over the years that have come through TrialNet, and we've been able to catch them before they end up in DKA, monitor the progression, start insulin early. I actually have some kids now that have 4 antibodies that we're following. The more antibodies you have, the higher risk of progression more rapidly. But that's one of the biggest areas that needs more research is, from stage 1 to stage 2 and then stage 2 to stage 3, how do we predict who's going to progress sooner rather than later, and then sort of intervention. And so we know, for example, there's actually guidelines that just got published, and the data is presented at the American Diabetes Association meeting this past month on monitoring kids and adults with preclinical diabetes, so stage 1 and stage 2. And there's some data that a 10% increase in your A1C predicts progression in the following year. There's also, you can use continuous glucose monitoring data. If they're spending more than 10% of their time above a blood sugar of 140, that predicts progression in the next year. And so we're learning more and more about how to identify that. The IA2A antibody specifically seems to be more predictive of sooner progression. We also know the younger you are, the more antibodies you have, the more risk you are of progression. So if you're a 3-year-old with 4 antibodies, we're watching you very closely.
Okay. So then what kids should we be screening? I mean, that's really kind of our question as the primary care doc, because, we want to be cognizant of using resources wisely and not over-testing, but obviously we don't want to miss these kids. So what kids would you recommend in our offices that we do test?
Great question. So currently the American Diabetes Association, they come out with the Standards of Clinical Care for Diabetes every year, usually in December. Gets published in January. The most recent publication recommends that all first-degree relatives get screened. So if you have a patient that has a sibling with type 1 or a mom or a dad with type 1 diabetes, they should be screened for those antibodies. And screening isn't just at one point, right? So we talked about how those antibodies can develop over time. You can screen as young as a year, and then sort of the younger you are, the more often you want to do that screening because they can turn positive pretty quickly within that first couple of years. So if you screen somebody at 1, you might do it again at 3 and then 5. And then if they get to 5 and they're still negative, you would spread that out to like every 3 years. And then if they hit 16, 17, 18, and their antibodies are still negative, you can stop screening and kind of provide reassurance to the families. So definitely first-degree relatives of type 1, or if there's multiple family members. So say there's a cousin and a grandma, you would want to screen that kid as well. There's also a recommendation to screen kids that have other autoimmune diseases. And the ones we see most commonly is we'll see kids diagnosed with celiac, who then sometimes get diagnosed with type 1, and kids with hypothyroidism, who then get diagnosed with type 1. And so those are the other sort of kids that could benefit from screening.
And do those screening intervals kind of follow the same schedule,
Yes.
depending on how young they are? Okay, so it's not like if they're negative if they have celiac, but they're negative once, you still will want to check them on that periodicity schedule.
Correct.
So with the islet cell autoantibody panel at Children's, what has your experience been with cost to the families? Because that's a question we get often in the office is we want to be cost conscious. We don't want to, sign up for a test that's going to cost us thousands of dollars. So what's that experience been?
So my experience is that in a first-degree relative, the cost is covered by insurance. Of course, we talked about deductibles. So if you have a deductible that you've not met yet, you're going to pay that. Generally speaking, it's about $200 for the test. So it's
out-of-pocket cost, again.
Yes.
Every situation is different, but your experience has been they're kind of around $200 if they have to pay the majority of the price?
Correct.
Okay, that's not too unreasonable.
Yeah.
And then if we get a positive result, what's our next step, and then what do you guys do in your clinic?
So the next step, if you get a positive antibody result, is to check an A1C to make sure that they don't at that point have clinical type 1 diabetes. Because you could get an A1C of 6.7%. They may not have a ton of symptoms yet, and you've just prevented them from going into DKA.
So a random or fasting glucose
you could get that. You could get that as well.
Okay.
Yes.
But
so
would
both.
you, if they were all, let's say just in your office you check a finger stick and it's in the normal range, would you still get the A1C?
Yes.
Okay.
Yeah.
For more long-term monitoring.
Yeah, because the A1C is an average over 3 months, and it is preferential to the most recent time frame. So even if you get a normal fasting in the clinic, we see kids, as I've been following these kids who are progressing from stage 1 to stage 2 to stage 3, we often see that the fasting blood sugar is the one that becomes abnormal last. The postprandials is kind of what you see abnormal first, and then eventually the fasting will become elevated.
Okay. So we check our labs. If their A1C is elevated and or a fasting or random glucose is in those concerning ranges, what options do we have to help them?
So the best thing is to call Priority Link, and that will get you straight to one of my colleagues in endocrinology, and we have Diabetes Day Hospital. So at new onset, if you're not sick, if you're not in DKA, we can do outpatient education, which is great for the families. We've been doing this for over 5 years now, and it's been a really great transition. So they come in from like 7:30 to 4. They meet with educators, they meet with social workers, they see a physician, they get started on insulin, all their prescriptions are taken care of, and then they come back for day 2 to complete the education. And then there's continual education even after that. And so Diabetes Day Hospitals is how, we care for those kids that do have clinical diabetes and need to be started on insulin. But your first step, if you were to find somebody with an A1C greater than 6.5 and positive antibodies, would be to give us a call through Priority Link. If you have somebody with positive antibodies but their A1C is normal, we would like to see them in prevention clinic. And so this is a clinic that I've started. It's called the Type 1 Diabetes Prevention Clinic, or Preclinical Diabetes. It's It's Friday afternoons throughout the year, and the plan is to increase the frequency of those as our population increases. Currently, just starting this since February, we have about 25 patients that we're following now with stage 1 and stage 2 type 1 diabetes. If someone lived far away or didn't want to come to Children's and wanted to continue care with primary care with positive antibodies, there are those guidelines that just came out on recommended screening. But basically, if they have 2 positive antibodies but completely normal A1C and random blood sugar, you're going to see them about every 6 months and do an A1C, and you're going to talk to them about the signs and symptoms of diabetes. If they're younger, you might watch them a little bit more closely, and the recommendation is to actually repeat those antibodies if they're less than 3 every 6 months to see if that 1 turns to 2, that 2 turns to 3. If you have someone with stage 2, so 2 antibodies and prediabetes, I would really strongly recommend you call us and bring them to us. Because there's now actually disease-modifying therapy that we can offer to families.
And what is that disease-modifying therapy?
So there's only one available currently. It's called Tzield. So I think about it as a shield against diabetes, Tzield, or the other name is Teplizumab. It was FDA approved in November of 2022 to delay the onset of stage 3. It's for kids age 8 and older with stage 2 type 1 diabetes. It is a 14-day infusion, which we will be doing at main campus in the infusion center. We are offering families PICC lines versus peripheral IV. But what this medication does is it actually sort of deactivates the T cells that are attacking the insulin-producing cells. So it directly intercedes with that autoimmune attack. And the data showed that giving Teplizumab delayed the onset of diabetes for an average of 2.7 years, which is pretty impressive. And when you look more minutely at the numbers, it was a smaller study. Part of that is because it's hard to find kids in stage 2 diabetes, since we're not screening. I might not have mentioned this, but 90% of those with new onset type 1 diabetes don't have a first degree relative. So that's a whole nother conversation about general population screening. We are not there yet in the United States. Colorado is doing it through research in their community. Some European countries like Italy have started general population screening. Again, we're not there yet in the United States, but that could be in our future. So with teplizumab, when you looked at the first year after infusion, so it was 76 participants, 34 of them got teplizumab. It was adults and kids ages 8 to 45 with stage 2, and they all came from that trial net study that I talked about, so first-degree relatives that were being screened for antibodies. And then the other folks just received normal saline. And in the first year, 0 participants in the teplizumab group developed type 1 diabetes needing insulin, but 8 participants in the placebo group. So, the study was not big enough to say, we think it'll work better in this person with these antibodies. But they're actually starting a registry, which we're going to be a part of, to follow patients who get teplizumab so we can get a better idea of, is there a more ideal candidate that we know that they're going to get those 2.7 years. And there are patients that got longer than that. There are patients that went 5 years after teplizumab without being diagnosed. And I kind of look at this as the tip of the iceberg. There's a lot of questions that it brings up. Can you give it again? We don't know yet. If you give it, every 3 years, will it delay onset inevitably? We don't know yet. But it's exciting because this is the first disease-modifying therapy for type 1 diabetes.
And, of course, recognizing everyone's insurance coverage and plans are different. What has been your experience so far with getting these therapies covered by insurance companies?
So we are still waiting for our first infusion here at Children's. I'm actually in process with 2 going through insurance right now, talking to other centers that have done infusions. Generally speaking, insurance is covering it. It does sometimes require prior authorization, which is not surprising. It is an expensive medication. And with that includes sort of the infusion, how you're giving the infusion, so PICC line or IV, and then the labs for monitoring during the infusion, and then the follow-up to that. And so they do have the company that makes teplizumab does have a company they're working with to help guide families through that process and absorb some of the cost if their insurance is not covering it. But Medicare and Medicaid have been covering it for the most part. Commercial insurances have been covering it. How much the family pays, I've heard as little as $50 and as much as your deductible. And so that's pretty variable, but we'll definitely work with families. We have a good prior authorization group here at Children's to try and minimize those costs to the patient.
So we've learned a lot about what kids to watch out for, how to get some testing done. I've certainly learned a lot about our understanding of the progression of type 1 diabetes. Are there any other resources that you would share with a primary care doc around type 1 diabetes?
So we have, on our children's website, we have a lot of information about diabetes. We've also created a knowing note that is actually becoming published this week, has gone through all the approvals on screening for type 1 diabetes. So that's something that providers could access through the Cincinnati Children's website that sort of goes through what are the stages of diabetes, why is it important to screen, what happens if you screen positive, and talks about those.
Any other websites or organizations that families can access for more information?
Sure. So the American Diabetes Association has information on type 1 diabetes, as does Breakthrough T1D, formerly known as JDRF. Also has an excellent website. The other website that often has like the latest and greatest, and it's run by people with diabetes. They go to all the conferences to learn the newest, is called diatribe.org, DIATRIBE. And they'll talk about all the newest technology. And that's one of the things I wanted to hit on. One of the responses I've gotten from families and sometimes other providers is, well, we have all this technology to manage diabetes. Why do we need an immune modulating therapy? And what I would say to that is, yes, we have great technology. I personally have had type 1 diabetes since I was 10, so it's been 34 years. And from where I started on NPH and regular insulin to where we are today with automated insulin delivery systems and insulin pumps and continuous glucose monitors, I would have not believed you if you told me this is where we were going to be in 34 years. But we still see a high burden of disease in patients. And so, yes, there's these pumps, but you have to fill them with insulin. You have to charge them. You still have to bolus for your food. And it's a lot to keep track of when you're trying to live life. And then, there's still disparities in our high-risk populations and minority populations. We have, a grant here at Children's with my colleagues, Dr. Jones and Dr. Carruthers, that are working on trying to improve access to all the technology for all of our patients with type 1 diabetes. But there's still a large burden of disease. And even with these AID systems, patients, kids, teenagers, and adults are not meeting A1C goals, which means long-term complications, which is not great for patients, but then also a bigger burden on our healthcare system.
Well, thank you, Dr. Sheanon, for all of your time and expertise today. For our listeners, a reminder that today's episode is available for CME credit. You can find a link to that in the show notes. And if you like today's discussion about diabetes, there is another podcast that we've done on type 2 diabetes and prediabetes that you can find the link to that in the show notes. Once again, Dr. Sheanon, thank you so much for your time.
Thank you for having me.